So now we're moving to the interscalene. And the interscalene was introduced by Dr. Winnie in 1970. Notice how Dr. Winnie was so instrumental in introducing so many techniques that we still use. It's just simply amazing to just think about all his volume of work. So here is celebrating his 80th birthday. That Dag Selander, who is a Swedish guy responsible for us using the short bevel needles. He produced a lot of in literature in local anesthetic. He loved the United States. He was so patriotic that he died the 4th of July. The interscalene block now will be the block in that same compartment that we talk about, the myofascial compartment, but will be done at the apex of the compartment. And now, just by showing you this image, which doesn't have the connective tissue and the fascia, notice that it makes sense to put the probe at the base of this triangular space parallel to the clavicle, and you see the cross-section of the subclavian artery, and then the cross-section of the divisions, plus the cross-section of the suprascapular nerve. But when you go up, because of the direction of the nerves, you don't want to remain parallel to the clavicle. And I think this image kind of helps visualize that. You want to eventually lift the lateral side more than the medial side, so you end up with a cut that is diagonal here. Make sense? So you can see C5 and you can see C6 in cross-section instead of getting an oblique cut of those same nerves. So you want to, you start here, and then you start lifting the lateral side more than the medial side, and then judge by image whether you got to the right place, and we're going to see that in a second. But basically, this image helps to visualize that. So don't produce a horizontal cut here, but a cut that is very, very diagonal to get a better image of the upper roots. Now, so, you know, we taught ourselves ultrasound in Dr. Voronov. I always remember being in front of, as he's usually, his mind works. We were still stuck to the nerve stimulator, and, we couldn't just release it from our hands, and he was already trying to do ultrasound imaging, good for him. So when we got to the interscalene, we all got to see things like this so frequently that that became known as the traffic light sign. Some people call it snowman. Is the apex of the space. So you see one on top of each other. So it was easy to call them C5, C6, C7. It was kind of intuitive. Although some people call it upper, middle, and lower trunk. So you can see here, this person called it C5, C6, C7, which is the most common. This one sees everything, which is not possible. This one calls it upper, middle, and lower trunk, I believe. And I love this guy because he called it nerve, nerve, nerve. So he is not wrong. He got it right on the money. Nerve, nerve, nerve. So the question at the time was, were really those C5, C6, C7? And so I did study in published in 2016, where we investigated the 3 dots, and actually ended up being, it was very curious, and I got this idea in my dissections for the ASA annual workshop. I will dissect the whole body, which was usually a nightmare because there was no help, and it was in a convention center, so the bodies were always kind of sneak into the place, and now you were into a corner trying to dissect with no lights, and you know how those convention centers have, ceilings that are so high, and that's the only light in the whole room. It was a nightmare, but I will dissect quite a bit, and I always noticed that C5 was so much smaller than C6, as you can see in this one of my samples here for this study. So I cut C5 at its origin and then C6, and then it's joining to form upper trunk, and C7, as you know, continues at the middle trunk. Here is another specimen, the same thing. Notice how C5 is so much smaller in diameter than C6. And if you investigate this, you will realize that C6, C7, C8, T1 are very similar in size. Usually C7 is the larger one by a small fraction, but they're very similar in size. And C5 is smaller. And I tried to find this written down, just as we are saying it now. And I noticed that Gray's anatomy actually draws C5 very small, but it doesn't say it's smaller. But at least you go back in time, you find somebody acknowledging that this is the fact that C5 is smaller. And that is very important in this thinking, because if C5 is smaller than C6, how could you explain that there's three dots of the same size? So then if that was C5, C6, C7, it would have to be a small dot and two dots that are larger and similar among themselves. But the C5 would have to be smaller. Well, it happens that what we found was that C5 is indeed smaller, and that C6, this is the spinal nerve C6, which is unifascicular, and immediately after it emerges from the intervertebral foramen, fasciculate usually into two fascicles. And there is a little bit of connective tissue that if I remove, notice how can I distinguish now the two fascicles. And what happened, we say that ultrasound fails to see sometimes what you can see easily on the naked eye. The difference between fat and muscle is usually very easy, when you're dissecting. However, ultrasound sometimes is able to see things much better than you see with naked eye. Ultrasound see that connective tissue as something different than the dense neural tissue. So it produces a septum there, and it kind of magnifies it, and you're able to see in cross-section 3 dots. So you end up seeing 3 dots, which are the result, the last 2, of only one nerve that is bifasciculated. So C6 has 2 fascicles, but those 2 belong to a single nerve. And you will say, big deal, Well, it's big deal because now if you inject in that gap, that second gap, between what you thought there were 2 different nerves, you're injecting intraneural inside C6 very close to the spinal nerve. So that explains why when the interscalene block was introduced, soon people started having epidural spread, and some of course will get total spinals and all sorts of things. They will think that they were so good that they did an interscalene, they end up with an epidural. So in people, Dr. Winnie gave me all his writings and his manuscripts, and and still haven't found room to put all those things in, a little bit before he passed away. And I have been reading through it. People wrote letters to him about the complications they were seeing, including death with the interscalene, soon after the interscalene was introduced. So I remember, Dr. Winnie was good at having, and Dr. Voronov should listen to this story. Every Thursday we'll go visit a professor, and we'll go to a nice restaurant, and he will pay with a corporate card. And so we will order all the, expensive stuff, and we have good drinks. And, after having some drinks, I will tell him interscalene is the most, dangerous block that has ever been invented. He will flip off his wheelchair and have another drink just to forget about it. But interscalene had that problem, and now you could actually put the finger into it because you know now that most likely we're doing injections as C6. And in the literature, there is a very, very bad example, and I don't know if I have it here, a very sad example, I should say, of this. This is a CT scan post-mortem of a 20-year-old that went to Haifa to get a rotator cuff surgery. He got an interscalene block with a catheter placed at that gap. And then this is before, obviously, we knew this. a resident came at night to inject the catheter, gave ACC of a 0.25% bupivacaine and walked away from him, and the kid died of a total spinal. So this is sad to acknowledge, since the solution is so obviously easy now to our eyes. But so it has an importance. So here we go back that those 3 dots correspond to actually only 2 nerves. And here I have my video. Hopefully it will work. So you can see how those 2 dots, those 2 distal dots are going to fuse into one when I push the probe in. You see the two fusing into one. See? And notice how C5 remains small. So there's 1 and 2. So notice how it's almost like magic. If you push the probe, you can interrogate those images and find out whether they truly are 2 different nerves, because you have to come with the assumption that every spinal nerve is monofascicular. So if you push your probe toward the transverse process, and that continues to be a single nerve, that is that continues to be a single dot, that's just a single nerve. So these 2 can be, you can be traced back for a few millimeters toward the transverse process, and you can find out whether there are indeed 2 separate nerves or just the 2 fascicles of a single nerve. So it's something important, not something peripheral in this understanding of the block. Well, but I thought that after we know all this, people would be now more relaxed, since people have been doing interscalene block since 1970s and enjoying them, but people panic about more information sometimes. So and please don't panic. You still, interscalene block has a good room for in our armamentarium blocks, and that is the shoulder. I'm going to just go over and just tell you that the shoulder innervation coming from the brachial plexus is a C5, C6 affair. There is no other large joint in the whole body whose innervation, that they're all complex, can be traced back to only 2 spinal nerves. That is something particular to the shoulder joint. So 97% of the innervation of the shoulder come from C5, C6. There is a marginal contribution to the capsule on the lower side, which comes from C7, which is meaningless in the whole picture, and there is nothing coming from C81. So notice that now, if you put all that information together, the fact that now you can isolate C5 and the 2 fascicles of C6, and knowing that the innervation of the shoulder is only coming from C5, C6, now you know that the interscalene block should be an easy block of injecting between the C5 and the upper fascicles of C6, a single injection. So no need to move the needle anywhere. In the YouTube, there is a YouTube that comes from Stanford, where somebody is in front of the machine there and does the interscalene block, whatever the way they do it. But then finally, the finale of the block is, then I like to direct the needle down here. So down here is down here, which in the old maps, the ancient maps was called terra incognita, where nobody knew what that were there. So nobody knows what is in there, since this is not an image. Oops. This is not an image to show the distal part of the brachial plexus. So you direct your needle down there. First, you don't know what you're doing. Second, it's totally unnecessary, not contributory to the success of your block. If you're using interscalene for what it should be used, only for shoulder. That includes the scapula and includes the clavicle. But you should not be using interscalene for anything else. Okay? I hope that it is clear. So we sit the patient up again, and just like for a supraclavicular, and we go from being completely parallel to the clavicle to a diagonal position. I'm holding the probe with different hand just to show the position, the final position of the probe. And there you have to do some tilting also in the anterior-posterior level just to get the best image. Notice that you're not going to a fixed space. You're going to move the probe until the anterior scalene and the middle scalene get together, and anterior. Oh, that was not the image, but you move your probe until anterior and middle scalene come together, like here. So you go from the base of the triangle up diagonally, and notice how the anterior and middle scalene approach each other, as is seen here, and then kind of encloses the space, and then you get to see the row of the upper roots. But just remember, those 3 dots correspond to only 2 different nerves. So I have to keep moving. Always people ask, what are you injecting? I mean, that is the least important of the whole thing, because provided that you inject local anesthetic, you're going to get the job done. So there is not that many local anesthetic. Here in the United States, we have mepivacaine, and it has been just by tradition, but if you don't have mepivacaine, you will use lidocaine. Lidocaine is an intermediate both in onset and duration, but in clinical practice is considered to be a short onset and short duration, the way things work. So if you want a short onset, most likely you will use mepivacaine or lidocaine, and if you want a long duration, you will use bupivacaine. Now let me say one more time. When you use bupivacaine for analgesia, do not use 0.5%. It's totally unnecessary, and it will limit the amount of local anesthetic volume that you can inject. So don't ever exceed 0.25%. You will get exactly the same analgesia for the same duration at a much lower risk. So keep that in mind. Every block that is analgesic should not be done with 0.5% bupivacaine. Now, if you're injecting bupivacaine to mix it with another local anesthetic, then you have to make your determination according to that.